Here, we are going to run through the bed capacity model for assessing the inpatient bed needs to handle the incoming COVID patients due to the current outbreak. The model you see in front of you basically is the patient experience, starting with symptoms through their care-seeking delay onto the type of care that they receive, and then into inpatient care, either medical care on an adult acute care unit or into an ICU for intensive care, depending on their level of acuity and the type of care that they need. And then through to mortality calculations and either recovery or death. This model is run and managed through these three buttons on the left. First is the settings button, and this is what we're going to start with. You have two options for running the simulation model. You can either run with limited or unlimited beds. We'll start with the unlimited because this is the most likely place that you're going to want to start. In the event that you want to run this model, this will allow you to estimate the number of beds that you would want to have in your hospital, regardless of whether or not it is feasible to rapidly scale up that number of beds and that amount of staffing capacity. But this assumes that you're able to do so and lets you know what you would like to have in an ideal scenario. Their first step in setting this up is to validate some assumptions. The data that is currently populated in these, that you can access through these buttons that links you to different dialogues, is the best available information as of the time of publication, which is currently March 25th, 2020. However, you may want to update this as you receive new information and that becomes available and publicly understood. The first item is to understand the acuity mix. So this has been populated to reflect the US population and the different age bands that they have. And by age group, what level of acuity would we expect to see for that particular patient? So for example, for a patient who is under the age of 19, 50% of those patients would be expected to be asymptomatic, 30% would be expected to seek home care and to need that level of care, 18% likely need some level of outpatient care and supervision, 2% inpatient hospitalization, and 0% would need the ICU. This data comes to us from the CDC, and this is the best known understanding of how hospitalization rates and ICU rates vary by age group. The next item is mortality rates. This is broken out similarly by age group, by location of seeking care, and by acuity. You probably don't need to update these numbers. Length of stay is something that you may want to consider updating if you have local information about how COVID care is happening in your hospital. There are 4 parameters here and 2 different subsets of patients. This is acuity for patients. Those are patients who need inpatient care, the min and the max length of stay. And for acuity 5, those are patients who are eventually going to need ICU care, their min and their max length of stay. This is broken out for time spent on medical surgical and then also on ICU floors. It is important to note that for patients who are going to be in the ICU eventually, they will spend half of their length of stay, whatever that is, on an acute care floor first, and then transfer to the ICU midway through their care. Care-seeking delays are important to consider if we are concerned the patients aren't seeking care properly. At this time, this is not a significant driver of the model, but it is an option to update irregardless of the level of care that is sought. Again, by patient acuity, 1, 2, 3, 4, 5, you can see the definitions here. What is the min and max number of days that a patient might wait before they seek care? And then finally, the delay-dependent mortality effect. So depending on what we think is happening in our emergency rooms, there is some literature that suggests that as ICU-eligible patients are delayed in the emergency room, they actually experience an increased rate of mortality. And so we see here that this has been populated based on what the literature tells us, but if you believe that you have a different type of threshold, please do enter that You can turn this on or off depending on your interests and your beliefs about how your system is operating and what the mortality is actually happening. Once you've reviewed all of those and you're comfortable with the assumptions, you can go ahead and select Next. And then you have 5 different options in terms of what type of epidemiological scenario you believe might be happening. The unmitigated outbreak is the baseline worst case scenario. In most cases, you're probably not going to want to run that because it's going to take a lot of time to run forward because there's going to be a very large number of patients. But in fact, that's not the world in which we are currently living, thank goodness. And so that's not really going to be worth spending the time and computational resources to run. For the most part, your baseline is actually going to be some level of moderate social distancing, and then you have other options that you might select from as well. Once you've done that, you can select Next. And then you need to finalize your settings. The number of trials to run is optional. You can set this to be whatever you would like, as long as it is greater than 1. The thing about this model is that it's stochastic. What that means is that every time we run the model, we're going to get slightly different results. Because of course, we know that even if the, say, average number of patients we expect to arrive in the hospital today is 10, sometimes it will be 8, sometimes it will be 12. It can vary. And so we want to simulate that variation, and that's what trials allow us to do. The more trials you run, the more confident you can be that the mean of the values of the trials that you've run is accurate to what you would really expect, right? Because we're running it enough times, we can be fairly certain that this is a reasonable approximation of how the system actually works. Something in the 10, 20, 30 range is probably reasonable for most scenarios. You can go ahead and update the duration of the simulation. For the most part, 12 weeks should be adequate, but feel free to up that if you feel strongly. You can put in your population size. Typically, we're going to run this at 100,000 patients. That's a reasonable runtime, and then we can extrapolate up to a larger population size. And then we can name our model for results export. Great, so once we've set all of those parameters, we just hit OK, 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 OK. It's going to tell us how long the model is approximately going to take to run. In this case, it tells us 16 minutes. And then it informs us that if we want to continue, we go ahead and hit OK, and then select the Run button, and that will start the model. Otherwise, we can cancel, change our settings, and then go ahead and run, depending on how we're feeling about the selections we've just made. I'm going to go ahead and hit OK, and I'm going to go ahead and run the model forward. You can see that the clock is running forward here. We're on run number 1, now we're on to run number 2, and given the parameters that we've selected, there are 90 runs that are going to happen. This is because we set that to be 15 trials, and there's a number of different scenarios that we've opted to run, and so this is going ahead and letting us know how far we are along in that path. And you can see it's running fairly quickly, and we should get results shortly. I am going to go ahead and pause that so that we can walk through some of the other options, but normally you would want to let that run to completion and then export your results. The other options that we have in here are to run with limited number of beds. So we're going to go ahead and open that, and this gives us a little bit more control. So instead of running the previous scenario where we said we can build beds infinitely fast to whatever level we would like, this actually lets us constrain the model based on what we know to be true in our current hospital system. There's 3 key pieces to this. First is setting the number of beds and the typical occupancy in a given hospital. So for example, if I have just one hospital that I want to run this for, I'm going to go ahead and clear this out. Say hospital 1. Let's say we have 350 acute care beds. Perhaps we have 85 ICU beds. 100% of the catchment population is going to go to this hospital because we only have one, so we can just set that there. And then occupancy is the percentage of beds that are typically occupied. So let's say that my routine acute care beds run at about 60% occupancy and my ICU at about 70% occupancy. I also have the option here to set an overcrowding multiplier. This allows me to tell the model that I'm going to allow patients to fill up more than these 350 beds. So if I were to say, actually, I'm going to I anticipate building an extra, let's say 10% of beds, or I am just going to allow sort of everybody to be a little bit more crunched than normal, I can go ahead and apply a 10% multiplier. I do that by setting it to be 1.1, so 100% plus 10%. It is important to note that these numbers for the beds and the catchment need to be greater than 0, as do the occupancy numbers, which need to be somewhere between 0 and 1, representing 0% to 100% typically occupied. Okay. The next set of assumptions are operational. So the first couple of items are related to patient behavior. So this first one is a question of how long will a patient be willing to tolerate being delayed in an emergency room while they wait for a bed before they seek care at another hospital. In this case, we're only running one hospital, so that's not a relevant parameter. But if I was running, say, 3 or 4, I could set that, and then patients would bounce back and forth between hospitals looking for open beds. The second value is also related to behavior, and this is the hospital behavior. So this determines the maximum wait time for a bed before patients have to be turned away. So once patients, in this case, start waiting up to 24 hours for an inpatient bed, they will be sent home and asked to wait at home instead in order to protect emergency room space and also protect them from acquiring hospital-acquired infections, including COVID. These patients are likely linked to care and would need outpatient supervision while they're waiting at home. There's also an option here to add an additional delay. So one of the things that we have been seeing with inpatients is that hospitals are not able to place them back into, say, skilled nursing facilities without a definitive test that demonstrates that they are not contagious with COVID. As a result, we end up having patients in hospital beds that wouldn't necessarily need to be for clinical reasons, but because we just can't place them anywhere else and we need to keep them safe. And so if we have a situation where, say, 10% of ICU patients are unable to leave promptly, we can enter that here, and then we enter their average length of delay. So let's say 10% of my patients experience a 5-day delay. Again, the percentages need to be entered as decimals between 0 and 1, and the days would need to be positive integers. The last parameter here that we would need to set up is the actual existing COVID census. If I'm running this model from, say, an early point in the epidemic, where I really don't have a lot of COVID patients filling up these available beds, then I can just leave this blank. If not, I need to go ahead and enter the patients into the system. So let's say I have 3 patients that are COVID patients that are currently in the hospital 1. This is patient 1, patient 2, and patient 3. This parameter, this column here, doesn't actually get used by the model, but it's just potentially useful for you for tracking. And let's say 2 of those are inpatients and 1 is in the ICU. And so far, their length of stay in the number of days is really important to enter here because this is going to get taken out of their normal length of stay. So let's say our first patient is randomly going to be assigned, say, a 12-day length of stay. If they've already completed 8 days, they're only going to stay in the model for another 4. So I'm going to go ahead and enter those values here. And then, are they actually in the ICU? So just because a patient is an acuity 5, they are eligible for the ICU, but that doesn't mean they have necessarily acquired an ICU bed. And so in this case, yes, they have acquired an ICU bed, and we're going to go ahead and enter that data. Great. So once I do this, these patients will be generated when I run the model, put into those beds, and then the model will start running so that we ensure that we don't sort of underestimate the utilization of our inpatient beds. Once I've set all of that up for my local hospital, I go ahead and select Next. This should look familiar. These are all of the same parameters that we've just discussed in the unconstrained or unlimited bed scenario. I'm going to go ahead and select Next. I can opt to also change not only the outbreak scenarios that I'm going to run, but also the capacity scenarios. So depending on what I think is going to happen in my hospital and how, when, and if I'm going to cancel elective procedures, I can assess a couple of different scenarios here. This is going to be my baseline, which is based on my typical occupancy. I also have the option to run 20% or 50% of that baseline occupancy being removed from my underlying demand. So that's essentially going to release additional beds into the system and allow more space for COVID patients. And then I'm going to go ahead and select next. Again, I can set the number of trials, which is going to allow me to run the same model multiple times, but with different stochastic realizations so that I can estimate the type of variance that I might see. Set the simulation duration, how long will it run for, my population size, and again, the name of the results export. I'm going to go ahead and select OK and close all of these out. Before I close this one out, I do just want to mention there is this reset defaults option here. If any of those parameters, such as acuity mix, length of stay, and care-seeking delays, you have the option to change those. And if you do, and you decide that you don't like it, and you want to just reset back to the defaults, you can just go ahead and select this button, and that will do that for you. Okay, I'm going to select OK. I do want to go ahead and run the simulation. So I'm going to go ahead and select Run. And you see, I added a few more scenarios when I changed my options in the capacity selection. And so here we can see actually I'm going to be running about 270 iterations of the model. That's 15 trials per scenario. And so we're going to go ahead and compare those at the end. Now I'm going to go ahead and pause this. You would normally want to let this run all the way forward and then let it finish, but I'm going to go ahead and pause, and then let's assume that the runs have completed. The number has gotten up to 270, the clock has stopped moving, and I can go ahead and select Export. This will export all of the results that have been saved for this model to, and those files will be named with this extension, and the results will be placed as CSV files into this folder. And so you can see in this case, I'm putting it onto my C drive into a folder titled Results. I can change this to be whatever file path that I would like it to be. I'm going to select OK, and now those results have been exported.